Hello everyone. How would you differentiate between AVRT and AVNRT? Go ahead and pause the video and think about an answer. In this session, we would be talking about the basics of understanding arrhythmias. So, when you're thinking about an arrhythmia, let's start off with the normal conduction system of the heart. You have the SA node. Now, this is the normal pacemaker for the heart. And from the SA node, the impulse travels to the atria and eventually the AV node where it slows down. And from here, it goes to the bundle of His, the right bundle and the left bundle. Now, normally, the SA node is the pacemaker because it's the fastest beating pacemaker in the heart. So, in other words, there could be other foci that are able to function as a pacemaker, but then these are actively inhibited by the SA node just because it fires much more faster than the others. So if you think about the underlying reason for some other focus taking over, it could be one of two reasons. So the first reason is something happens and the SA node stops functioning. So because now the SA node is no longer functioning, one of the other cells might take over the function of the SA node. Another reason could be that something else is faster in creating an impulse compared to the SA node. So in other words, you have a faster impulse generation. Now, the faster impulse generation could be for one of two reasons. The first one is that something happens and one of the foci is shooting impulses way faster. So one of the impulses is shooting impulses at a very fast rate. And a second thing that could happen is something called the re-entry phenomenon. So think about it this way. It is possible that within the heart, there is a conduction pathway that is relatively fast and another conduction pathway that is slower. As a general dictum, the conduction pathway that's fast has a higher refractory period, and the one that's slower has a lower refractory period. So when talking about refractory period, we're referring to the phenomenon when a certain cell is in its refractory period, it is resistant to depolarization. So in other words, when a cell is in refractory period and an impulse goes to it and tries to depolarize it, it would resist that and not get depolarized. So let's say the impulse originates in a specific area. It approaches both the fast and slow conducting pathway, and then it obviously travels through the faster conducting pathway and travels forward. And then when the impulse approaches from the slow conducting pathway, it might hit a refractory period and get blocked here. And this phenomenon would repeat after every impulse and things are going okay. Now let's say something changes and something happens. So for instance, there's another focus of the heart that gives off an impulse prematurely. Now when this impulse is generated, it would approach again both the fast pathway and the slow pathway. But then the problem is the fast pathway could be in its refractory period. And so it's no longer able to pass this way. So this impulse is blocked. And so what might happen is the impulse would travel through the slow pathway and then it would go down as predicted. But then if at this point when it touches the area close to the fast pathway, if the fast pathway is no longer refractory, the impulse might go backwards, and then the impulse that went backward then go back and stimulate the slow pathway, and this cycle might repeat rapidly. And when this happens, you have the re-entry phenomenon, and this can induce an arrhythmia. So examples of such re-entrant pathways would be AVNRT and Wolff-Parkinson-White syndrome causing an arrhythmia. So from what we've discussed so far, the SA node is the normal pacemaker in the heart because it has the fastest rate. Now, if something happens to the SA node, another focus might try and take up its function and keep the heart going, or another focus in the heart might just be faster than the SA node, in which case it would end up generating the waves of depolarization in the heart. And lastly, the faster impulses generation could be because of the re-entry phenomenon. So when thinking about arrhythmias or abnormalities of rhythm, let's focus on where the specific abnormality is arising from. So normally, the pacemaker cells in the heart are located in the SA node. And we said that the SA node shoots off impulses at a rate of about 60 to 100. And this causes P waves that look essentially normal. So this would be normal sinus rhythm. Now, in several normal individuals, when they breathe, the heart rate increases. So when they breathe in, the heart rate increases. And when they expire, breathe out, the heart rate decreases. So there is a mild variation in heart rate with respiration. And this would be sinus arrhythmia. So, in other words, when you breathe in, the heart rate going up, and you breathe out, the heart rate going down would cause the EKG to have slight irregularity, and that would be sinus arrhythmia. Another possibility that might happen is that the SA node is still the pacemaker, but then it just beats slower. So you end up with a heart rate of less than 60, but the P waves are okay. And this would be sinus bradycardia. Now, another thing that might happen is that the SA node is still the one that's causing the waves of depolarization in the heart, but then it just happens to do so faster. So the rate is more than 100, and this would still cause the P waves to look normal, and this would be sinus tachycardia. And in both these cases, the P waves look okay and the underlying rhythm is regular. The only difference between a normal sinus rhythm, sinus bradycardia, and sinus tachycardia is based off of the rate. Now, another thing that might happen is that the SA node keeps beating, but all of a sudden there is a delay in the beat and then it resumes beating again. So when there is this pause in the activity of the SA node, you call that sinus pause. So in essence, in the EKG, you would expect to see regular P waves, and then all of a sudden there is a pause, and then the P waves could resume. Now, one thing that can happen is some focus outside of the SA node might actually fire prematurely. So this focus fires prematurely, and this would create a wave of depolarization earlier than expected. And also, the way that the atria are depolarized when SA node is the pacemaker would be different from the way the atria are depolarized when there is an external pacemaker, because the pathways change, and so the shape of P wave is different. Additionally, because this focus is at a different distance from the AV node compared to the SA node, the PR interval might be different. And lastly, this may or may not be conducted to the ventricles. And this would be a premature atrial contraction. Now, an alternative would be you could have another focus in the atria, and because something happens to the SA node and it doesn't fire, this one beats as a means to keep the heart going. In other words, this would be an escape rhythm. So what's happening is that normally the SA node fires and so the escape rhythm is inhibited, but then because now the SA node is not firing, the escape rhythm takes over, and you would now see a wave that's later than expected. And even this would have a shape of P wave that's different from that of a normal P wave. The PR interval could change, and the difference between a PAC and an escape beat is that a PAC happens earlier than expected, and an escape beat or rhythm is typically later than expected. Let's go ahead and draw the atria. You have the SA node. And for some reason, you might have another focus in the atria start firing out rapid waves of depolarization. And so you would end up with a higher heart rate. And also the P waves would look different. And this can cause something called atrial tachycardia. Now, sometimes there could be a re-entry circuit that's established within the atrium, and so you would see a faster beating heart rate that kind of causes characteristic wave pattern, and this would be atrial flutter. And whenever there are these faster beating heart rhythms, tachyarrhythmias, there might be an underlying heart block. We'll talk about heart blocks later on, but essentially think about it as you might see multiple P waves, but not every one is followed by ventricular depolarization. So not everyone has a QRS complex. And lastly, the atrial activity might be totally haphazard, and you might not really see any P waves whatsoever, and that would be atrial fibrillation. So in this case, you actually wouldn't see very clear P waves and the heart rate becomes very irregular. So no clear P waves. And you would see irregular heart rate. Now, sometimes it might be challenging differentiating atrial tachycardia from atrial flutter. And one way to think about it is that atrial tachycardia is usually slower than atrial flutter, and flutter waves are pretty much always close to 300 and typically associated with a 2:1 heart block. So when you look at the QRS complexes, you would see about 150 QRS complexes a minute. And when you look at the flutter waves, you would see about 300 flutter waves. Lastly, if something is wrong with the SA node, so if the SA node is not working, one of the other foci in the atria might take up the role of an SA node, and you would see an escape rhythm. And you might see P waves that are different in shape from the normal P waves, and they're also slower. So this can happen with an escape rhythm. Now, sometimes, especially in people with COPD, you might see that the origin of the high heart rate is from several different foci within the heart. And so you see P waves that are all different in shapes. So the P waves are of different shapes. And in addition, the PR intervals constantly change. So when you see this and the heart rate is high, you would call that multifocal atrial tachycardia. And if the heart rate were normal, you would call it wandering atrial pacemaker. So again, in both these conditions, the impulses don't come from the SA node, but they're coming from several different foci within the heart. And so you end up with P waves that are all of different shapes, and the PR interval also changes based on how close it is to the AV node. And so you end up with this specific rhythm. Now let's go ahead and draw the heart, and we would talk about AVRT and AVNRT. So we said that the normal impulse from the heart starts from the SA node, goes to the AV node, and from there it goes into the ventricles. So that's the SA node, that's the AV node, and from there it's going into the ventricles. And the AV node should be the only area that's conducting impulses from the atria to the ventricles. Now, if there is a re-entry happening at this point, you would end up with AVNRT. So AVNRT is AV nodal re-entry tachycardia. And typically, what you would see is that because the impulse isn't originating from the SA node, the P wave is abnormal. And based on where in the AV node the impulse is originating, the P wave may be either just before the QRS complex, so you could have something like that. It could be within the QRS complex and you might not even see it, or sometimes it might be just after the QRS complex. So you have the QRS and then a small blip that you would want to look for very closely. So when we're talking about AVNRT, the impulse is originating because of a reentry phenomenon happening very close to the AV node, so the morphology of the P wave would be different, and the P wave is either immediately before or within or just after the QRS complex. Now, in some people, in addition to the pathway that connects the SA node to the ventricles through the AV node, so this one, there is another pathway that directly connects the atria to the ventricles. One condition would be Wpw syndrome. So the way you would think about WPW is that the impulse initially travels from the SA node to the ventricles through this point, but then the conduction system is not as efficient. So initially, you would see this P wave, and then the PR interval is lower. So the PR interval is lower because it doesn't have to go through the AV node where it's slowed down. So you see a P wave followed by a short PR interval, and then because the conduction system isn't as efficient, you would see a slow slurred upgoing wave. So this wave is called the delta wave. And eventually, the impulse does go through the AV node and follows the normal conduction system. And so, normal conduction system resumes, and the QRS complex looks okay from that point on. So, when you're thinking about WPW syndrome, the way you would diagnose it is by picking up the short PR interval and also the delta wave that's caused because the impulse is not going through the AV node initially, but instead going through the accessory pathway. Now, again, because you have these two pathways, 1 and 2, there could be a re-entry phenomenon happening here. So if a re-entry phenomenon happens because of this, so you have an impulse going in a loop like so, you would have atrioventricular reentrant tachycardia, so AVRT. The impulse is essentially going in a circuit between the AV node and the reentrant pathway, causing the AVRT. Now, notice one thing here. If the impulse is getting conducted in this fashion, so if it goes like so, the impulse is going through the AV node, and so you would end up with a narrow QRS complex. But on the other hand, if the impulse were going the other way, so let's say the impulse is going through the accessory pathway and back through the AV node, you would have a wide QRS complex. And so in AVRT, you could look at a tachycardia, and it could either be narrow or it could be wide based on which way the impulse is following. So let's draw back the conduction system in the heart. So again, you have the atria, and then you have the ventricles, the SA node, AV node, and then, the right and left bundles, and so on and so forth. So sometimes you can have an impulse that originates from the junction, from close to the AV node, and these would cause junctional rhythms. Now, if these are happening because the SA node isn't functioning, you would see escape rhythms, so escape junctional rhythm. Or if it's happening because something here is beating faster than the SA node, you would end up with junctional tachycardia. And again, as you would expect, the P waves would be of an abnormal shape. And because they're not having to go through the AV node, they might be immediately before or within or after the QRS complex. Now, everything we've talked about so far have happened above the ventricular level, and these would all be considered supraventricular tachycardias. And because all of them end up somewhere near the bundle of His, and following that, the conduction is essentially normal, these tend to be typically narrow. Now, are they always narrow? The answer is not necessarily. For instance, if a person has an underlying conduction defect to begin with, so old conduction defect, the QRS complex could be wide. Another thing that might happen is you have a rate dependent block. Rate dependent block. So when the heart rate is normal, the conduction system within the ventricles is okay, and so the QRS complexes are normal. But then when the rate is really fast, a part of the conduction system in the ventricles might be in a refractory period, and so you would see a conduction block only at high heart rates. So conduction block at high heart rates may be seen. And lastly, as we talked about in AVRT, when there's accessory conduction pathway, this might cause a wide QRS complex. So as a general dictum, while supraventricular tachycardias are narrow, there could be exceptions, and some of the common reasons include a pre-existing conduction defect, a rate-dependent block, or an accessory pathway. Now, sometimes the impulses might just originate from the ventricles, and impulses originating within the ventricles are usually wide complex. So, in essence, ventricular arrhythmias are wide complex. Some common examples would include the following. If for some reason there is no impulse coming from above the ventricle might kind of go into an escape rhythm, and this would be termed idioventricular rhythm. So, in essence, you would see wide complex QRS, and you may see retrograde P waves, and usually the heart rate is pretty low, it's less than 50. Now, if the impulses originating in the ventricle have a rate of about 50 to 100, then you would again see wide complex QRS, and this would be termed accelerated idioventricular rhythm. And if the rate is high, then it could be one of two things. The first one is ventricular tachycardia, and the second one is ventricular fibrillation. Now, when we're talking about ventricular fibrillation, the QRS complexes make little sense, and all you might see is a very uneven baseline looking like that. There really is no rhyme or reason to what you see in the ventricles. Now, when we're talking about ventricular tachycardia, you might see one of two things. The waves might be monomorphic. You might see QRS complexes that are about the same, or you might see a polymorphic pattern. And the polymorphic pattern would show QRS complexes of several different morphologies, and it might look something like this. So notice how this is more irregular, and the shapes of QRSs change pretty often, unlike monomorphic ventricular tachycardia, which is fairly regular, and the shape of QRS complexes is fairly even. A couple of things at this point. Using the term supraventricular tachycardia doesn't really convey a whole lot of information other than saying that the rhythm is originating above the level of the ventricles. So, when possible, you would want to be more descriptive of the diagnosis. So, for instance, you might want to commit to AVNRT or atrial flutter or whatever the case may be. Lastly, understand that cardiologists who've specialized in arrhythmias don't even agree on some of the EKGs. So when you're trying to interpret an EKG, always focus on what your impression of what's happening is and focus on the underlying principles of the EKG. Try and explain whatever you see in such a way that makes the most sense in the clinical context. In the next sessions, we'll look at real EKGs and try and interpret them. Thank you for watching.